So what's hypothyroidism going to do? Well, if hyperthyroidism speeds things up, hypothyroidism is going to slow things down. So they're going to have a cold intolerance. They aren't just chilly in here today. They're buttoned up with a scarf. They're wearing a sweater in July, or sweater vest at least. That's just fashionable. How are things going to move through their digestive system? Fast or slow? Slow. They have constipation. And they're going to tell you, man, I feel tired. And they'll chart fatigue or lethargy because everything's moving slow. Weight gain? Yes. Depression? Okay. Dementia? Sort of. Hair dryness and or loss. This is an interesting one. Hair dryness and or loss. Because something that's not in the textbooks, but I'm telling you. Classic hypothyroidism. Lateral thinning of the eyebrows. So starting from here, the eyebrows start to fall out. And they get thinner and thinner. So you'll notice these patients are going to have shorter and shorter eyebrows. It's not in your textbooks, but I'm telling you. Classic. Bradycardia, of course. Menstrual irregularity in either one, of course. Why? Because if you mess with hormones over here, something else is going to happen over here and over there. Most common type of hypothyroidism is something called Hashimoto's thyroiditis. And you're going to know somebody with this. And you're thinking, I don't know any Japanese people. I'm telling you, you're going to know somebody with this. Hashimoto's thyroiditis, most common form of hypothyroidism. Now, how do we fix these things? I'm sorry? Which one? Brian, here's what I want you to do. I want you to wow everybody and say both.
Okay, both.
That's brilliant. But how can you cure both with just Synthroid? What is Synthroid?
It's a synthetic.
It's synthetic thyroid hormone. But why would that fix somebody who has too much?
Because it helps it.
No,
Because
not at all. Because what we're going to do to fix somebody with hyperthyroidism,
We're going to surgically remove it.
we're going to cut it out. Well, if we cut out their thyroid, then what's going to happen?
They have no hormone.
They're going to be hypothyroid, which means they're going to need Brian bring it home.
Synthroid.
There you go. You see how that works? So you can give that answer. That just wows everybody. So yeah, eventually they're going to need Synthroid either way. Now, we check every child in the United States when they're born. You know, it's right for hypothyroidism. Every child is checked for congenital adrenal hyperplasia, hypothyroidism, biotinidase, galactosemia, and phenylketonuria, at least. And the reason for this is because if the child has congenital hypothyroidism, they're going to end up mentally retarded. And that's not good. But it's an easy fix. All we got to do is give them Brian.
Synthroid.
There you go. You see? That's it. That's all you got to do, and you can fix this. That's why we test the kids for this. It's not terribly common, but if it does happen, it's an easy, easy fix. And it will, you know, avert something very serious. Mary, you had a question?
Well, my question was about Synthroid. I wanted to know why are there so many dosages and why are they so small, like micrograms? And there's so many. Because
Because this, first of all, this is powerful stuff. The thyroid hormones are exceptionally powerful. You don't need a lot to do a lot. And we're talking about controlling, we're talking about a lot of control. changing metabolism is going to change a lot of things. So this is also why patients are will find that they have to have their doses sort of changed, because the body would have done that on its own. And all of us, hopefully, if all of us are having a thyroid that's working the way it's supposed to, there's always signals coming back saying, okay, did we send enough? All this over here. Do we need more now? Do we need less now? Do we need more now? Do we need less now? Was that enough the last time? Should we change it the next time? And without having that in place to make those decisions, all you're really doing is just guessing, you know? And that's okay. That's what we can do. Okay. Thymus. The thymus produces something called thymosins. These are important when it comes to the maturation of different types of white blood cells. This is the one that is located behind the sternal bone, the thoracic cavity. This is the one that actually gets smaller as we get older. Remember when we were babies, we have baby-sized heart that becomes adult size. We have baby-sized liver that becomes adult size. We have baby-sized thumb that becomes adult size. Everything else grows. This does not. This actually becomes smaller. The pineal gland, the pineal body, like I said, this is about melatonin. Pancreas, terribly important. Blood glucose. It is a yellow, lumpy-looking, triangular-shaped gland that starts just right of the midline and then tapers over to a point over near the spleen. So the head of the pancreas is just right of the midline, and then it tapers over to a point, the tail, over near the spleen. The head of the pancreas is tucked inside the first part of the small intestines, the duodenum, because it does release digestive enzymes directly into the duodenum. Blood sugar rises. Why would blood sugar rise? Well-fed state, right? Pizza Friday, best day of the week. That's because that's the day I get pizza. That's why it's called Pizza Friday. Eat as much pizza until I go into an insulin coma, basically. Pass out in a recliner watching a DVD. It's a great Friday. I'm sorry? Or house, no. No, I would never fall asleep during this. Blasphemous.
You'd have terrible dreams.
That's some bad hat, Harry. So, oh my goodness, I swear to God. So our blood sugar rises in the well-fed state. We eat a lot, get a lot of sugar in. Now we got to do something with it. Insulin comes in, the delivery guy takes it where it needs to go. Not enough blood sugar. We say, okay, we got to get some out of storage. Let's go to quick storage first. Glucagon comes in, takes it out of the closet. Takes that glycogen back to glucose. Notice how they work opposite of one another. Now, if a patient doesn't have any insulin, if their pancreas isn't working, what do you call that? Insulin dependent. We call it diabetes, type 1. We don't really use the term insulin-dependent diabetes mellitus or non-insulin dependent diabetes mellitus anymore, because we find that if a person has a type 2 diabetes, for a long enough period of time, eventually they are going to need insulin. Eventually they will become dependent on insulin. It didn't always work that way. There was a time where we wouldn't see diabetes until a patient was 65 or 70 years old. And other than with type 2. The type 1, of course, anywhere from 0 to in their 20s, because this is something that's caused either by a genetic problem or maybe a viral problem. Could be a viral problem. Why? Because we don't know what caused it. It's a virus. Blame it on a virus. So it could be a viral problem, but now the body's not making any insulin. That's the type 1 diabetes. So those patients, we don't have a choice. What are we going to give them? We got to give them insulin. That's the very first thing. Then we're going to talk about lifestyle changes, right? We're going to make sure they're eating healthy and exercising, etc. Type 2 diabetics, we didn't see them until later in life. It wasn't until they're in their 60s or so that we started seeing type 2 diabetics. And this wasn't the result of suddenly they weren't making any insulin. They were making maybe as much insulin, or maybe the doorways that were created in the cells, they just weren't opening as well. You know, glucose is a big molecule. It can't just go through a cell membrane. It has to open up a doorway. And glucose doesn't know the code. That's what insulin is for. But over time, these doorways aren't opening as easily for glucose. So we need to help them along. And that's where the glucophage, metformin, would come in. It would help with sort of greasing the wheels a little bit, making everything work a little bit better. And that would work for a while, and then it wouldn't. And that would work for, we have to increase the dose, and that would work for a while, and then it wouldn't. Then increase the dose and work for a while, increase the dose. And then they would die. Because at that point, they're 90, 95 years old. But the problem is, over time, you start seeing this in younger and younger patients in their 50s and in their 40s. Well, if you keep trying to up the dose and up the dose and up the dose and up the dose of metformin, after a while you get to a point where this doesn't help anymore. And now it's not working at all. So now what do? Well, now we got to give them insulin. That's the only thing that'll work. So we can't really call it insulin or non-insulin dependent diabetes mellitus anymore. So that's not really true. We used to call it adult or juvenile onset. Well, now we see juveniles getting type 2 diabetes. And this is basically this is all about diet and exercise, right? Because why did we see this change where people were getting diabetes at an earlier and earlier and earlier age?
Obesity.
Nintendo. Partly Nintendo. Nintendo and McDonald's. Or McDrive-thru. I don't want to say that name. I don't want to use any brand names. I don't want to get sued.
No.
You're getting sued. I'm not getting sued.
As I drink out of my Burger King cup.
It's interesting. If you look back at history footage from the 1950s, 1940s, you look at the streets of New York, try to find somebody who's overweight in the crowd. It's kind of tough. Why is that? Well, they didn't have the access to food that we have now. If you're hungry right now, you can call somebody up and they will deliver food to you. And this can happen now. In some places, you can call them up at 3 o'clock in the morning and they'll deliver food to you. Worst case scenario, and I mean worst case, you have to leave the house and go to a Wawa at 3 o'clock in the morning to get food. Worst case scenario. Now, there was a time where if it was 10 o'clock at night and you were hungry and there wasn't anything to eat in the house, what would you do?
Wait until the morning.
You'd have to wait until the stores open in the morning, and then you might have to walk several blocks, maybe a half a mile. Not anymore. People don't do that anymore. They're hungry 10 o'clock at night, they go online. Pizza now. I want pizza now. Send pizza now. Deliver shrimp now. Shrimp can't be here already. That was a Family Guy episode. Fast shrimp delivery. In my head, it's hilarious. Okay. So we have all this access to food. We don't have to move for it. We don't have to kill anything. All we have to do is let them bring us food. We do as little as possible. We don't have to, we'll take an elevator instead of taking the steps. How many times have people circled around the mall looking for a closer parking spot? When you're going into the mall, which is where you're going to be walking all day, it's not like you can't walk. Clearly you can, most of you. Clearly you can do the walking. It's just a little extra walking. But people will do what they can to get out of exercise. So that's why we started seeing this at an earlier and earlier and earlier age. And of course, are carbohydrates the enemy? No. But in excess, they cause problems. And that's what happens when all people do is eat the drive-through stuff, because that's all they're getting, excess carbs. All right, nobody cares. And you should care. Let me tell you why. Let me tell you why when people get diabetes, why you need to care. Diabetes mellitus. Now, okay, let me tell you right now, you will hear about type 1.5. There is a type 1.5. There is a type 1.5. However, there's still a lot of speculation about it. To me, it sounds a lot like type 2. It doesn't sound any different at all to me, but FYI. Type 1, this is the one that happens early in life, 0 to 20, right? Type 2, anytime in life, is a result of poor nutrition, poor lifestyle choices, which is why when this happens, the first thing we do is lifestyle modification. If we can do that first, we can reverse this, stop them from being on any medication. But if that doesn't work, then we go to metformin. And then eventually we'll probably have to go to insulin. All right, now, most of the people in the United States who have diabetes have type 2. You know that? Did you know that? Yes or no? Yes, no? Now you know it. Most people in the United States who have diabetes have type 2 diabetes, which is a poor indicator, because this is something that we can really stop, or at least decrease the number of greatly. All we have to do is eat healthy and exercise. And that's pretty much it. All you have to do is the same stuff that you learned in kindergarten. Remember that food pyramid? It's pretty much the same. We cut out a little bit of the red meat, minimize, don't cut it out completely. And then add a little bit of the good fats. But otherwise, it's pretty much the same. And then exercise. Like your parents used to say, go outside and play. We could eliminate a whole lot of type 2 diabetes. Now, here's the problem with diabetes. People don't take it seriously. They really don't. Because most people, the laymen out there, when they hear the word diabetes, what do they think of? They think of insulin, what else? Sugar, what else? Not being able to eat exactly what they want. That's not maybe having to stick their finger with that little needle. That's not terrifying. And it should be. Because the problems, the real problems that come with diabetes are things like diabetic retinopathy, which is why the patients go blind, because their retinas get destroyed. Diabetic neuropathy. If you destroy the nerves, that means you don't feel things, right? So, let's go back to earlier in the day. What happens when I get cut on the bottom of my foot?
Walk fine.
You walk fine. Oh, you're saying, oh, when I get, okay, yeah. I walk with my heel on the ground, my foot up. Why do I want to do this? Because it hurts otherwise. Well, what happens if I take the hurt away? Then how would I walk?
Normally.
I would walk normally, right? Why? Because I wouldn't know there was an injury there. Does that make sense? Didn't we say before the reason that we walk like this is not because it hurts. I mean, that's the reason we think we do. But the real reason is so that we don't make the injury worse. We give the opportunity to heal, and we keep pathogens from moving on in. If I don't have that pain, then I don't know, which means I'm going to walk around like this, which means what's going to happen? It's going to get worse, it's going to get infected. Right? This is why diabetic patients can't clip their own toenails. Because they'll just cut right through the skin. Don't know any difference. Something else we see is atherosclerosis, which is all arteriosclerosis, a type of arteriosclerosis, which of course means that blood's not going to flow as well through those small arteries, which means the heart is going to have to work harder in order to push the blood through, which means they're going to have congestive heart failure, they're going to have cardiomegaly, they're going to have peripheral vascular disease, which means they're not going to be able to get as many of their immune response cells to an area. So now, not only do we have an infection because I'm walking around on this cut foot, but now my white blood cells that I would want to get there, and some of the chemicals I want to get there aren't going to be able to get there. That's a problem. It's also going to reduce blood flow to that area, which means tiny, tiny vessels aren't going to have blood flowing through them, which means tissue that's waiting for that blood is not going to get blood. And what's going to happen to that tissue? It's going to die. And what loves dead tissue?
Bacteria.
Bacteria. So what do we do to dead tissue? Cut it off. This is why we amputate those toes, and then the front part of that foot, and then the whole foot, and then do it below the knee or an above the knee amputation. Have you seen this? And then, a big deal is diabetic nephropathy, renal failure. This is a big deal because when a person's kidneys stop working, they have 2 weeks to live. Remember we talked about the 3 most important organs in the body are what? The brain, followed by the heart, followed by the kidneys. So when the kidneys stop working, you got about 2 weeks. That patient has 2 weeks to live. If you go to a dialysis center in the United States, you will find about 9 out of 10 of the people that are there have diabetes. Almost 90% of all the people in this country who are on dialysis because of diabetes. That should scare people. That's what people need to think of when they think of diabetes. Not sticking your finger, maybe some insulin, possibly not being able to eat all the cake you want. But what should cause them some alarm is having their legs chopped off and getting wheeled in to a dialysis center that they can't see very well because they're partially blind. And then when people are on dialysis, what are they waiting for? One of 2 things.
Kidney transplant.
Kidney transplant
Or dying.
right? They're not going on dialysis saying, boy, I can't wait to stay on dialysis for the rest of my life. They're saying, boy, I really hope I can change this. Almost 90% of everybody, every patient in a dialysis center is there because of diabetes. That is horrendous. And the reason that is so bad is because most patients in the United States have what type of diabetes?
Type 2.
Type 2, which is preventable, which is something that could have even been reversed if they would listen to us, not just to me, to us, because now you're a part of this, because now you know. That is the frustrating thing. You want to tell these people, listen, just do that stuff that I told you to do, and this won't happen to you. And it still does. Okay. Oh, if that doesn't scare you enough, gentlemen, one of the other complications, common complications of diabetes is erectile dysfunction. So if dialysis, having your legs chopped off, going blind, and cardiomegaly weren't scary enough, think about the final. Think about that complication. Now, every medical textbook on the planet will tell you the first thing you see in a diabetic patient is polyuria, polydipsia, and polyphagia. Polyphagia is always eating, always hungry. Polydipsia is always thirsty, always drinking. And polyuria, always peeing, right? Now, that's not really accurate. Because what's the problem? In either type of diabetes mellitus, elevated blood sugar must be controlled. Why is the blood sugar elevated in these?
not being delivered to the cell.
It's not going to where it needs to go, inside a cell, inside a storage cell, or inside a cell that needs it. That's why it's elevated. If there are cells that need sugar, and they're not getting sugar, what's that going to mean for energy production? Low. Excuse me. Low, right? So, really the first things that are going to show up is fatigue. Patients say, I'm tired, I have no energy. Lethargy, or mental dullness.
No energy state.
Decreased cough reflex. Decreased urinary reflex. In other words, you're going to have more urinary tract infections, more respiratory infection. That stuff's going to show up probably. The lack of energy, that's going to show up before anything else does. They'll just write it off as something else. But the reality is, you don't have sugar going in, you're not going to be able to make energy. Just go back there. It's not a trick, it's not where the show. Sorry. Please know about diabetes. Please share this information with other people. Let them know that diabetes is not just about having sugar. They will know other people, they'll have seen other people with diabetes, they'll have heard of other people with diabetes. They will have seen them getting their legs amputated. They say, well, you see what happened to so-and-so? That same thing's going to happen to you. It's not, it might happen to you, it could happen to you. It's going to happen to you, it's just a matter of time. You want us to cut your leg off now, or should we wait? Yes.
In your opinion, do you think those patients in the dialysis center, they're educated by then?
I think that, well, it depends on what you mean by education. I think they had the information a long time ago. I think they ignored it. And by that time, it's just too late. I tell people all the time, I've told you, I think already, that it's not a good idea to go through McDrive-thru and eat that type of food on a regular basis. But how many of you have continued to do that? How many people have changed? Yeah, how many of you things? If we're being honest. You know what you're supposed to do, but you don't always do that. So I go back to that, the food pyramid in kindergarten. Every one of us learned that. Every one of us learned the food pyramid. Every one of us learned it's better to exercise than not exercise. We know this. We just don't want to do it. Why? It takes work. I got stuff to do. Like what? I got to take a nap. Nap time. Then after the nap, there's going to be lying on the sofa watching TV time. By that time, my pizza should be delivered. Ready for my insulin coma. So sometimes I think, I used to get flack. There were times where I would have to tell patients, you know what, you're too fat, you need to lose weight. And people would say, oh my God, that's horrible. Why would you say that to them? That's a terrible way to say it. I say, because they knew I was serious. Because if I say to a patient, I'm concerned about your weight, you might need to lose a few pounds, I want you to lose a few pounds, you know what they're going to hear? I'm concerned, blah, 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 blah. I'm going to have to change my diet, forget that. Exercise, no way. I'm not going to do that. He says he's concerned. Doesn't sound like I'm dying, right? But when you say something to a patient like, you're too fat, you need to lose weight, it's gonna kill you, and it's gonna kill you slowly and miserably. They take it a little more seriously. It's unfortunate. I'm sorry?
You'll lose that patient.
Yeah, well, that's why I'm teaching now, isn't it? Okay. That's pretty much the reason. What? Did you say I killed them? No.
They killed themselves.
That's the first thing you learn in medicine. First, kill as few patients as possible. Oh man, we have a lot of these. The adrenal glands. The adrenal glands are located on the superior aspect of each of the two kidneys. Two regions, the adrenal cortex and the adrenal medulla. This is very similar. This terminology should already sound familiar, cortex and medulla. If it does not, you will hear it a lot more as you learn more and more about the organs in the body. You will hear a lot about cortex or medulla and different organs. So the adrenal cortex, the outer layer, the adrenal medulla is the inner layer. The adrenal cortex, the outer layer, is actually divided
3 layers.
into 3 layers. The adrenal medulla in the middle of the gland. The adrenal medulla is where we find epinephrine is made and some norepinephrine. Although most norepinephrine is made in the brain. And remember, the difference between norepinephrine and epinephrine is 1 methyl group. That's it. Just take 1 methyl group on it. Epinephrine has a methyl group, norepinephrine does not. Epinephrine, also known as adrenaline. Effects include increased heart rate, blood pressure, respiration, along with profuse sweating and a dry mouth.
Good
Things to know. The adrenal cortex makes dozens of steroid hormones. The adrenal corticoids include the mineral